Hello and welcome once again to APHA's 15 on COVID-19 series. I'm your host, Dan Zlott, APHA Vice President of Education. Today we're going to be finishing our update on hydroxychloroquine. There's just been so much information that's come out. It's taken us a couple episodes to get through it all. We'll wrap that up today and move on to other topics after this episode. I, as usual, have nothing to disclose. Here are the learning objectives for today's presentation. All right, so as we mentioned last episode, there have been a lot of new studies that have come out, and today we're going to be talking about 2 randomized controlled trials and the outcomes of those trials. So without further delay, let's go ahead and dive in. All right, well, let's go ahead and dive into our first study of the day. So this is a single center randomized open label controlled trial in 62 patients. So we're starting to see the patient numbers creep up a little bit. Again, this isn't a huge trial, but bigger than we've seen in our randomized trials to date. The inclusion criteria, and another thing is we actually do have formal inclusion-exclusion criteria, hence this was a prospective trial. The age greater than 18, patients had to be COVID-19 positive by PCR. They had to have a chest CT with evidence of pneumonia at baseline. They had to have mild illness as defined by an arterial O2 over a pulse ox O2 ratio greater than 93%, or an arterial oxygen over FiO2 ratio greater than 300 millimeters of mercury. And again, do keep in mind that's one of the Berlin criteria for mild ARDS. So again, they're looking for patients with mild symptoms. They had to be willing to participate in the study. Moving on to the exclusion criteria, patients had to they were excluded if they had severe or critical illness. Patients were excluded for retinopathy or other retinal diseases. Again, think of some of the complications of hydroxychloroquine. If they had conduction block or other arrhythmias, again, think of some of the complications of hydroxychloroquine. Severe liver disease, so that was defined as patients with Child-Pugh score greater than or equal to C, or LFTs greater than twice the upper limits of normal. Pregnant or breastfeeding women were also excluded. Patients with severe renal failure were excluded. And if it was anticipated that patients would transfer to another hospital within 3 days, they were excluded. And then if patients had received any experimental therapy for COVID-19 within the prior 30 days. Now keep in mind that in the Chinese studies, they consider other antiviral therapies to be standard of care, not necessarily experimental. And so those are not included as part of this exclusion criteria. So what were the endpoints of the study? The first one was changes in time to clinical recovery. And so they define that as normalization of temperature and cough relief, which is maintained for at least 72 hours. Additionally, they looked at radiological changes on chest CT between day 0, which they defined as the day before hydroxychloroquine treatment started, and day 6, which is the day after hydroxychloroquine treatment ended. And they defined those changes in chest CT in one of 4 different ways. They said it was either exacerbated or worse than baseline, unchanged from baseline, moderately improved from baseline, and that was 50% improvement in terms of the pneumonia findings on chest CT from baseline, or significantly improved, and that was where more than 50% of the findings indicative of pneumonia improved compared to baseline chest CT. In terms of the patients here, there really were no statistically significant demographic differences between the groups. That said, the authors did not go into comorbidities at all. So we don't really know if there were any disparities in terms of the types or frequencies of comorbidities, the severity of comorbidities. And of course, as we know from some of the other literature in COVID-19, it's pretty clear that some of those comorbidities may play a significant role in outcomes, and in particular mortality. And so that's one of the potential limitations of this study, and we'll come back to that as we get to the end of the trial. All right, so now let's take a look at the intervention. So this was hydroxychloroquine 200 milligrams twice a day for 5 days, plus standard treatment, or standard treatment alone. Now, standard treatment consisted of oxygen therapy, antiviral agents, antibacterial agents, and immunoglobulin administration. The authors did mention that they had the option of giving corticosteroids or not. Presumably that was for acute respiratory distress syndrome or the management of ARDS. So some patients got corticosteroids and some did not. All right, well now let's go ahead and dive into the results. So Here's a table that summarizes the results, and you'll notice that compared to the control group, there was a significant improvement in both the time to normalization of temperature and the time to resolution in cough, and those were both statistically significant. So we're seeing some clinical differences here suggesting that the hydroxychloroquine arm did better. And then they move into their findings on chest CT. And here they find some interesting little bits of information. So when you look at those 4 categories individually, they didn't report statistics on them. So whether that was exacerbation, unchanged, moderate improvement, or significant improvement, they didn't go into each of those categories individually. However, if you take a quick look, there's some interesting findings there. In terms of exacerbation, we see more exacerbation in the control group, 9 patients, as compared to only 2 in the hydroxychloroquine group. In terms of unchanged, it's roughly about the same, 4 in the hydroxychloroquine group and 5 in the control group. With regard to moderate improvement in chest CT, we see 6 patients in the hydroxychloroquine group with moderate improvement and 12 patients in the control group. So it might seem that maybe control is better, until you get to the next category, which is significant improvement in chest CT. And there we see that 19 patients in the hydroxychloroquine group had significant improvement, and 5 in the control group had significant improvement. So what they did is they took a look at total with improved chest CT findings. And there were 25 patients in the hydroxychloroquine group out of 31 that had significant or that had improvement on chest CT, whether it was moderate or significant, as compared to only 17 in the control group. And so when they did the statistical analysis on that, that was statistically significant, just barely, but still it was statistically significant. And you can see the p-value there. So more evidence of improved outcomes in the hydroxychloroquine group as compared to the control group. Now, the authors report almost anecdotally that in terms of progression to severe illness, no patients in the hydroxychloroquine group progressed on to severe illness, whereas 4 patients in the control group ended up progressing on to severe illness. There was no statistical analysis on that, so they didn't report out a p-value there. So let's continue on with the results. So here we have a safety report out, and here they mention that 2 patients had mild reactions to hydroxychloroquine. Those reactions included 1 patient with a rash and 1 patient with a headache. Again, they emphasize that both of these were mild and of short duration. So what were the limitations of this particular study? First, patients received other antiviral therapies. Now, this is true of both groups, so presumably that was an equal confounder in both the control arm as well as the hydroxychloroquine arm. But as we'll see in the next study, that may play a bigger role than we're able to account for. Additionally, the types and numbers of therapies weren't specified in the manuscript, so we don't know if everybody was equal, if one group got on average of 4 therapies, whereas the other group only got 2 therapies, so that wasn't reported, so we can't really assess that. As I mentioned earlier, patient comorbidities weren't discussed or assessed in the manuscript, and so again, that's a huge potential confounder if there was unequal distribution of comorbidities amongst the groups, and because they didn't report on that, we don't know whether that's true or not. And limitation, or maybe not necessarily limitation, they didn't look at the time to viral clearance, and that's one of the open questions, and the next study we're going to take a look at will help us answer that. But this study didn't do that. This was really looking only at clinical outcomes, and they did find a difference in clinical outcomes. One other thing to point out, it's highlighted in the reference for you, but this entire article has not been peer-reviewed. So whether that's a limitation of the study or not necessarily, but you do have to keep in mind that this has not been through the normal review process. So this is very preliminary data. And as the review process continues, this manuscript may change a bit. So certainly not in final form. So do keep that in mind. All right, so let's take a look at our next study. This also is another article that has not been through the peer review process. Just because of the rapidity with which we're trying to get information out about COVID-19, we're seeing a lot of articles that are in press that are in the peer review process that have not yet undergone peer review, etc. So let's take a look at this study. This is a multi-center, open-label, randomized control trial in 150 patients, so very similar to the last trial, but even bigger, so more than twice as many patients. And this one again has formal inclusion-exclusion criteria. The exclusion criteria here were greater than or equal to 18 years old, COVID-19 positive by PCR. They had to have the availability of a baseline chest CT scan, just like the last one. And then the exclusion criteria were patients who are unable to take oral medications. Again, they're going to be giving hydroxychloroquine orally. Patients with known allergy to hydroxychloroquine, cognitive impairments or mental status issues that would prevent patients from complying with a study protocol, pregnant or breastfeeding women. So looking at the endpoints for this study, the primary endpoint was viral clearance at day 28. And that's interesting. It's quite a bit further out than some of the other studies we've seen. So it's an interesting endpoint, and we'll talk about whether or not it plays into the results at all as we get to maybe some of the study limitations. Secondary endpoints included viral clearance at 4, 7, 10, 14, and 21 days post-randomization. They also looked at improvement in clinical symptoms at 28 days, and they defined improvement in clinical symptoms as normalization of temperature, being able to maintain oxygen saturation on room air, as well as resolution of respiratory symptoms. This group also looked at improvement in chest CT at 28 days. They were looking for normalization of laboratory parameters at 28 days. And as we'll see, they were really interested in lab parameters that were indicative of inflammatory responses. So they looked at C-reactive protein, or CRP, erythrocyte sedimentation rate, or ESR, both of which are known to be sort of non-specific indicators of inflammation or autoimmune disease. They were also looking at IL-6 levels as well as TNF alpha. And so again, if we think back to some of the processes that we know are responsible for maybe some of the more severe symptoms of COVID-19 disease, it's thought that a lot of them are actually due to the immune system's maybe overly potent response to the virus in certain tissues, in particular lungs, as well as some other organs. So interesting mix of lab parameters there that they're looking at. They also measured days of mechanical ventilation, whether or not patients needed ECMO, extracorporeal membrane oxygenation, how much supplemental O2 support was required, and then the length of hospital stay. So those are all the secondary endpoints. So what was the intervention in this trial? Well, the intervention was standard of care, and then they added in hydroxychloroquine. And this dosing schema is a little bit different than we've seen before, and the duration is also different than we've seen before. So patients were started off with a loading dose of hydroxychloroquine, 1,200 milligrams a day for 3 days, followed by 800 milligrams a day for a total of 2 weeks in patients with mild symptoms, or up to 3 weeks in patients with moderate to severe symptoms. So both the loading dose is unusual, as well as the duration of therapy. That's far outside the realms of what we've seen described previously. So not exactly sure what to make of that, but we'll take a look and see when it comes to adverse reactions maybe. And then the other arm, of course, was standard of care alone. The analysis was an intention to treat analysis, so they get points for that. They actually did a true intention to treat analysis, and they actually followed patients through and sort of told you where patients dropped out, what happened at each step of the way. So they did a nice job of following their patients throughout the study process. And then all enrolled patients were included in the safety analysis. So again, more bonus points for them for doing what we consider to be sort of the gold standard in terms of reporting. All right, let's take a closer look at the patients who were included in this study. There were 150 patients total. It was a 1-to-1 randomization between the hydroxychloroquine plus standard of care arm and the standard of care alone arm, so 75 in each. The median age of these patients was 46. 55% of the patients were male, and the average number of days from symptom onset to randomization was 16.6. Now, this is interesting. This is significantly longer than we've seen in other studies. If you think back to the Gautret et al. Study that we talked about in our previous episode, it was between 5 to 7 days between symptom onset on average to the start of hydroxychloroquine azithromycin in that particular study. So this is a deviation from the norm. So we'll talk about that again when it comes to some of the limitations of the study. Almost 90% of patients were receiving COVID-19 directed therapies prior to randomization, mostly antivirals, but a number of other things. 99% of patients had mild or moderate COVID-19 disease at randomization. Only 2 patients had severe illness at the time of screening. So again, we're seeing more of the mild to moderate grouping, although they do include a couple of severe patients here. The median time follow-up at the end of the reporting period was 20 days in the hydroxychloroquine group and 21 days in the standard of care group. So pretty similar there, about 3 weeks after randomization. So what were the results? Let's take a look at viral clearance to start off with. That was the primary endpoint. Viral clearance at day 28 was pretty similar between both groups. 85.4% in the hydroxychloroquine arm, and you can see the 95% confidence interval there, and 81.3% in the standard of care alone arm. Again, you can see the 95% confidence interval, nearly identical. There was no statistically significant difference between the two groups. So here we've got some more evidence that maybe viral clearance is not as good with hydroxychloroquine as we initially thought. So we'll come back to that again at the end. Interestingly, they also looked at the median time to viral clearance, not just at day 28, but how long did it actually take to achieve viral clearance. And they found also that the time to viral clearance was similar in both groups, 8 days in the hydroxychloroquine group and 7 days in the standard of care alone arm. There's the hazard ratio for you. You can see that the 95% confidence interval crosses 1, therefore it's not statistically significant, and the p-value again just reinforces that. A post hoc analysis of the subgroups did not identify any statistically significant differences in time to viral clearance in any of the subgroups analyzed, and we'll take a look at that in just a second. So this is figure 1, and this is just looking at the time to viral clearance. And so as you can see, these two lines basically overlap. The solid blue line is the hydroxychloroquine group. The dashed red line is the standard of care group, almost identical. And again, the statistics are there for you. So now let's take a look at the subgroups. So this is the subgroup analysis that they performed, and the way that they did this was basically through a series of hazard ratios. And as you can see, no matter which subgroup they did an analysis on, there was no statistically significant difference here. All of the 95% confidence intervals for all of the subgroups crossed the 1 mark, so nothing there significant. So based on this, it seems pretty clear that, at least in this study, hydroxychloroquine had no impact on time to viral clearance. All right, so let's take a look now at clinical outcomes. So the improvement in clinical symptoms at day 28 was similar between both groups. So again, this is 28 days out from randomization, so 4 weeks out from randomization. 60% in the hydroxychloroquine group. Again, you can see the 95% confidence interval there. 66% in the standard of care alone arm. Again, you can see the confidence interval there. It's a little bit wider, but for all intents and purposes, these are statistically about the same. The median time to improvement in clinical symptoms was also similar between groups, 19 days in the hydroxychloroquine group and 21 days in the standard of care alone arm. So again, no significant differences here. However, when they did a subgroup analysis of patients who had not received other antiviral therapies, there was a statistically significant improvement in the rate of symptom alleviation in the hydroxychloroquine group. And so the hazard ratio for that was 8.83, and the 95% confidence interval is pretty wide, as you can see, 1 all the way up to 73. However, it does not cross 1, and so therefore it's statistically significant. It's important to note this is a post hoc subgroup analysis, so this should be used for hypothesis generation only, not for evidence of efficacy necessarily. Post hoc analysis of other subgroups didn't identify any statistically significant differences in time to viral clearance in any of the subgroups analyzed. So this is the improvement rate, so it's sort of the opposite of the graph. So the higher the number, the more patients have demonstrated improvement in their clinical symptoms. Again, the hydroxychloroquine group is in blue, standard of care group is in the dashed red line, and the statistics are there for you. These are pretty clearly almost identical. So now let's move on to the subgroup analysis. And here you can see for most of the subgroups, there really was no difference in terms of the clinical improvement or time to clinical improvement with or without hydroxychloroquine, with the exception of those patients who had not received other anti-COVID-19 directed therapies. And this is, as we mentioned before, the statistically significant improvement there. All right, so the last piece of interesting information is from Figure 7, and here the authors were looking at CRP and lymphocyte count in the hydroxychloroquine versus the standard of care group, and you can see that there was a statistically significant decrease in CRP in the hydroxychloroquine group as compared to the standard of care group, and that's interesting as well. We know that hydroxychloroquine is a potent anti-inflammatory medication. Obviously, it's used in a number of autoimmune disorders. So this just helps to confirm that there are significant decreases in inflammatory markers. On the other side of that, you may note that the lymphocyte count increases in patients getting hydroxychloroquine. And you might be wondering, how is anti-inflammatory response associated with an increased lymphocyte count? Well, we think that when there's a potent inflammatory response, the lymphocytes move out of the blood and into the tissues. And so the lymphocyte count goes down. Remember, what we're measuring from is the blood. And so you'll see less lymphocytes in the blood. And so when you can decrease the immune response in the tissues, you'll see more lymphocytes return into the blood, and so you'll see an increase in the number of lymphocytes in the blood, in the circulatory compartment, or again in the blood. And so that was not statistically significant, but they did see an increase in the lymphocyte count. So just something of interest. All right, so then the last thing the authors really reviewed was the safety profile. So not surprisingly, there were more adverse events reported in the hydroxychloroquine group than in the standard of care alone arm. And the incidence of adverse events was 30% in the hydroxychloroquine group versus about 9% in the standard of care group. That was a statistically significant difference. The most common adverse event was diarrhea, and it was 10% in the hydroxychloroquine group versus none in the standard of care arm. And that's, again, statistically significant. Now, it's interesting, this is a little bit different than some of the other trials we've seen where even patients who were not getting hydroxychloroquine did experience some GI issues just associated with COVID-19 itself. So again, slight difference there. It's difficult to know exactly what to make of that. This is the controlled trial you'd like to see, so this is the definitive answer. In the hydroxychloroquine group, there were 2 patients who experienced severe adverse events, and the severe adverse event was dry mouth and sore throat in one patient, and that led to a dose reduction, and then blurred vision in another patient. And again, keep in mind with the retinal toxicity associated with hydroxychloroquine, that's obviously pretty serious, and so hydroxychloroquine was discontinued in that particular patient. Both events were noted to be reversible within 1 to 2 days of onset. 1 to 2 days of discontinuation or dose reduction of hydroxychloroquine. So on the whole, very well tolerated, even though there were an increased incidence of adverse events. All right, well, let's discuss the limitations of this study. So the biggest one, of course, is that it included patients with other antiviral therapies. And as we saw from the data from this very trial, the biggest benefit seemed to be present in those who had not received prior antiviral therapy. So it may be that by including those other antiviral therapies, they're masking some of the potential benefit of hydroxychloroquine. So we're not really sure. But certainly the practice in the treatment practices in China with regard to COVID-19 seem to vary pretty significantly from what we're seeing in the United States. So we're not giving 3, 4, 5 different antiviral therapies, which is pretty common when you look at the Chinese literature. So it's difficult to assess whether or not this experience coming out of China will be replicated here in the United States. So open question. The hydroxychloroquine dosing was pretty different than we saw in other studies. 1,200 milligram load for 3 days, and then 800 milligrams a day thereafter. And they gave that for 2 to 3 weeks, whereas a lot of these other studies were giving hydroxychloroquine for 5 days or 10 days. So again, just a sense that this is not exactly an apples to apples comparison. But again, this was a controlled trial, so we do have controls within this particular trial to assess the differences. And then, of course, there were more than 16 days from symptom onset to the initiation of hydroxychloroquine on average. And so that's a pretty significant difference. When you look at some of the other studies, the Gautret et al. Group, for example, they started within 5 or 6 days of symptom onset. They had patients on hydroxychloroquine and azithromycin. And so this is certainly an extrapolation. So just to be clear, this is theoretical. But if we look at other models of viral illness, like flu, for example, we know that early intervention is critical in order to reap the benefit of antiviral therapy. And so whether the same is true in COVID-19 with hydroxychloroquine remains an open question. If that is true, certainly 16 days, after 16 days, you wouldn't necessarily expect to see much of a benefit, and that's sort of what we saw here. So again, these are sort of finer points and a lot of open questions yet, but on the whole, this is obviously much higher quality data than we've seen in the past. Lastly, there was a limited patient population with severe COVID-19 disease. Most of the patients who were included had mild or at most moderate disease. There were really only 2 patients who had severe illness at the time of randomization. All right, so we've looked at a lot of data over the last couple episodes, and finally we've arrived at the new bottom line. So what is the new bottom line? Well, it's looking like hydroxychloroquine may not be as effective in increasing the rate of viral clearance as was initially first reported in randomized controlled trial. It really hasn't shown any benefit in terms of increasing the rate or frequency of virologic clearance compared to control groups. However, it does appear that hydroxychloroquine has some clinical benefit, and that clinical benefit, there's a little bit of a range depending on which study you look at, but we saw improved chest CTs in one group, we saw improved clinical symptoms, that's reduction in temperature, as well as resolution of respiratory symptoms, and the question is whether or not that's true in all patients or just those patients who have not yet received antiviral therapy. It's an open question. One trial showed benefit, one didn't. However, what's clear is that in both trials, the data was limited to patients with mild to moderate disease. So the benefit in patients with severe COVID-19 is still largely unknown. So we're going to need some more data to help us answer that question. So that's the new bottom line for now. Stay tuned. I'm sure it will change again in 3 weeks, 4 weeks, 8 weeks. We'll do another revisit and we'll have more information to share with you. All right. Well, that will wrap up today's 15 on COVID-19 episode. This coming Friday, April 24th, we'll take a look at a couple of other areas of update, including some of the new viral properties that we're learning about, surface stability, aerosolization, etc., as well as some of the new information that's come out about remdesivir and what we can learn about the utility of remdesivir in COVID-19 from that information. So we hope to see you on Friday. As always, please keep the COVID-19 questions coming. We continue to receive wonderful and amazing questions, and they're so helpful to us in terms of planning future episodes. So with that, thank you once again for joining us, and we hope to see you on Friday.